Dan Winkle. I'm the Director of Healthcare System Initiatives with the American Cancer Society, and I'm pleased to host this afternoon's webinar, Palliative Care in Oncology. Our speakers today will share their perspectives on integrating palliative care into oncology practice, as well as resources available to support cancer centers and oncology teams in achieving quality care measurements associated with integrated palliative care. Our first speaker today is Rebecca Kirch. Rebecca is the Society's National Director for our initiatives addressing quality cancer care and quality of life for adults and children facing cancer and its aftermath. Her efforts have been honored with the Center to Advance Palliative Care's 2013 Innovation Award and a 2015 Presidential Citation from the American Academy of Hospice and Palliative Care. And this summer, she will also be receiving the 2015 Distinguished Public Service Award from the American Psychosocial Oncology Society. Joining Rebecca is Dr. Lynne Padgett, who is a Program Director at the National Cancer Institute in the Division of Cancer Control and Population Science. Dr. Padgett is a technical lead for the NCI Community Cancer Centers program in the areas of cancer survivorship and palliative care. Her program of research focuses on measurement issues related to cognition and emotional distress, as well as interventions to improve or maximize cognitive functioning. She's particularly interested in the process of implementing biobehavioral science into community clinical practice, facilitating research with community partners, and organizational factors associated with the practice of palliative care. As a reminder, today's webinar will be recorded, and a recording will be sent out to everyone who registered for the presentation, as well as the slide deck. So be on the lookout next week for that. And I would also like to take the opportunity for a couple of housekeeping items. After our speakers complete their presentations, we will have the opportunity for Q&A, and you'll notice that there is a Q&A section on your screen. And when you enter or submit questions, you can do that anytime during the webinar. Just make sure that you address those to all panelists, and that is the default. So when you enter in, just don't change any of the settings on that Q&A. And then also at the very end of the webinar, we will be doing a very short survey, just asking for your feedback about the webinar and any input on future topics. So thank you again for joining, and I'll now pass the microphone over to Rebecca Kirch.
Thank you, Stephanie, and welcome everyone to our webinar. We're pleased to have you with us. And I'm going to provide a brief overview just to get us rolling, and then we're going to really help roll up your sleeves with Dr. Padgett's help on some very useful practical advice and tools and tips to help make sure that you get rolling with what you know is already available, because our goal here is to help support and be your partner in improving the patient and family experience. And we have staff on the ground available to help you, but also resources available to help you work in your communities while we're detailing to your hospitals to help support what you need to address this major priority for patients and families. Their quality of life and what matters to them is as important as what's the matter with them. And what we hear all the time, the American Cancer Society is one of the major patient and family voices of healthcare. We hear from them often, and you probably too in your settings, that, you know, the quality of my living is as important as the length of my living, and treating the pain, symptoms, and stress of my cancer and what happens after it is as important to me as treating the cancer. So that's really what our webinar is about, and the opportunity we have to work together to bring palliative care to all seriously ill adults and children. And so when we look at the numbers, the statistics, we know we have a big job to do, and the cancer centers are overloaded already, but the good news of that story is that the number of survivors is really rising, but we need to then adjust the health system to handle those changing demographics of the cancer population. What we know is that this number of survivors of cancer and those in active treatment are in the millions, and many of them, if not most, do experience, because of the toxicities of treatment and the aftermath of cancer, a great deal of emotional and physical suffering that we are equipped now and have evidence to help minimize. And so the new mantra and the new way that we're approaching care is something that we're all embracing together, and that's about surviving and thriving, improving survival together with high quality of life. Now, children present a particularly compelling case because those toxicities of radiotherapy and chemotherapy happen when their brains are growing and their bodies are developing. And we know from the literature there's particular attention that needs to be paid here in terms of long-term survivorship to address the late effects and support for the families and the siblings as well. We featured childhood cancer statistics as a special section in our Facts and Figures of 2014 and called out this emerging literature from the childhood cancer survivor studies showing what we now know about the late effects of hearing in these children as they become adults. So it's a newer area of public health interest and intention for making sure that we fulfill on the promise of high quality of life alongside longer survival. And there's been a great deal of activity. We were delighted to see the sort of numbers for registration for this webinar today because it shows that palliative care and this quality of life agenda is really a hot topic for everyone. And that makes a great deal of sense. ASCO is fully behind it, the National Comprehensive Cancer Network and the Commission on Cancer, for example, have all come out with their accreditation and quality care standards that all of you on the front lines in your cancer centers and institutions every day are trying to operationalize. And the Institute of Medicine captures so beautifully in its Quality Cancer Care Report what we now know about the picture of cancer for today and tomorrow and addressing the long-term survivorship issues, as well as caring for people through the end of their life, and the importance of focusing on their emotional and physical functioning through provision of palliative care and psychosocial support as part of active cancer treatment. Not something we reserve till later on, but from the point of diagnosis as depicted here, throughout the continuum of care, these are essential elements of the full suite of quality cancer care. So from the American Cancer Society's perspective, what we're really talking about now is helping shift from what used to be an either-or construct. We either did curative or palliative, or heaven forbid, sometimes we still say versus, but really it's about putting both together. This is collaborative care. And it's about reorienting the priorities to make sure that people's understanding, whether it's the public or clinicians or administrators and cancer center directors, understand that really palliative care is a key lifeline to quality of life from the get-go. And the opportunities that we have to make sure it's embedded into mainstream medical care are many and really essential for any age and any stage of disease. And we want to make that message clear for every audience, for the clinical workforce, even researchers, as well as the public and policymakers. So that's really what our agenda is all about. One way that I like to frame it up for people to help them understand is a little like how Amazon.com delivers its product. Alongside chemotherapy, you may be also interested in making sure you have palliative care to support your emotional and physical needs to help get you through treatment as effectively and comfortably as possible. So this really, again, is all about the opportunity we have to provide integrated care, and the importance of communication is sort of the bedrock of all of this, to make sure that we're focusing on what's important to patients and families as we help work with them to prepare treatment plans and care plans across the continuum into long-term survivorship and throughout care to the end of life. All of these pieces in the green box, palliative care, psychosocial care, and impairment-driven rehabilitation, as well as other integrative therapies for addressing symptoms and preserving wellness, are an essential part of delivering good quality care. And there's a lot of help available from partners and colleagues on the palliative care and psychosocial care team side, and physiatrists and other rehabilitation specialists. They can all be part of delivering this high-level care while we're delivering disease-directed treatment that focuses on halting progression. That communication core as the bedrock is something we'll also touch on here a little bit in terms of the resources available to help clinicians have the words to use to make sure patients get the care they need, and also to help support and empower patients to talk about these things. So what the American Cancer Society has done in partnership with its advocacy affiliate, ACS CAN, the Cancer Action Network, is partner with major national pioneers and organizations in the field, including some of the logos here, and this is not an exclusive bunch, but really to come up with a strategic framework for action through research support, program delivery, and advocacy, including legislative policy, to tackle this problem and help work to bring palliative care everywhere. It's something everyone understands, demands, and is equipped to supply, not just at the specialty level, but at the primary care level of palliative care as well. And so some of the strategies we're focused on, first and foremost, really hit on this need to help people understand and give them the words to use to get this care that they need. Many times, particularly when I talk with oncology audiences, they'll talk about the resistance or the reluctance to bringing palliative care up early because many were trained and think of it as something we do only when there's nothing left to do or at the end of life. But the literature, the evidence has shown very much different, that palliative care is part of everything we do from the get-go to make sure that patients are able to continue and complete their disease-directed therapies, and also to provide that support for the family. So we, together with the Center to Advance Palliative Care, invested in important consumer research to sort of take it out of the discussion chamber that it was happening in and really take it to the street and ask people, what are the words that you would use to explain what palliative care is? Because what we learned and what's shown in this pie chart here, that big red space is the blank slate that the public represents of really not understanding what palliative care is at all. So it's not that we have to unlearn it, other than perhaps among clinicians who were trained longer ago and think of it as something we do after treatment concludes. It's really a matter of all of us singing from the same song sheet to explain that palliative care is part of what we do alongside cancer therapy to make sure that you get the best care possible. And what we've learned is we don't need to change the name, we just need to be consistent with the words we use and align them with what patients and families tell us palliative care has meant for them. So it's about giving these words to use so that people get the care they need. And our consumer research came up with a definition that's featured here that focuses on those things that patients and families hold dear. This is what strikes at their soul. Relieving the pain, symptoms, and stress of their serious illness, whether it's cancer or something else. Making sure that quality of life of both the patient and the family is an on-par priority as we make decisions about treatment and follow-up care. And this is care that's appropriate all across the spectrum for children, for adults, for seniors, at any stage of disease. And it can be provided right alongside disease-directed therapy and curative treatment. When we use that definition, which is what the resources you're going to hear about use consistently, that steady drumbeat of same message will stick. It will help raise awareness and encourage patient demand, and that helps drive practice change. But look at what the public told us about that definition. Once they heard those words and had those equipped to use, they said this is something essential that everybody should be told about and know about so they can request it. It's something that I would consider for myself and my loved one, indeed. And overwhelmingly, people say this is something that should be accessible in hospitals, and I would add other care settings, every care setting nationwide. And that's really the focus of our strategic goals, to bring it there. There are some wonderful resources to supplement what the American Cancer Society has developed from partners of ours, and I featured one here from the University of California, San Francisco, Prepare for Your Care. The website is shown. This is a wonderful quality of living tool to help patients and families at home have conversations and make plans so they can have a more effective encounter with their clinicians about what matters to them, so that that's a prioritized part of the clinical conversation right alongside how we treat what's the matter with them. And there's a really great new game. It sounds kind of funny to say, but it's true. It's actually a table game for families, clinicians, others to use called My Gift of Grace that I just feature here for all of you to have a look at, because it's a stunning new opportunity for us to talk about the quality of how people want to be living until whenever it is that they are not. and the opportunity we have to help make that so, while we're also supporting clinical communication skills building through a partnership that we ran for 3 years with the creators of OncoTalk, now called Vital Talk, and we did a number of workshops in several regions, 9 over the last 2 years. But I feature here the importance of this because oncology teams and others really need that scaffolding for helping transition their practice to focus on what matters to patients and families in terms of shared decision-making and goal-directed care. And vitaltalk.org has excellent resources available for clinical teams to do so. Alongside this, there's an advocacy agenda that we're advancing to sort of build that echo chamber of understanding across the nation for policymakers and for the public to raise awareness. And this features 2 ads from ACS CAN, our advocacy affiliate, which capture in a beautiful visual what palliative care really is. And the campaign message, again, is about quality of living and treating the person beyond the disease as equal priorities of quality care. There's a robust and growing coalition backing up this campaign effort, which involves both federal and state legislation, but also regulatory work and other public awareness. It's the Patient Quality of Life Coalition, and it's something I hope you'll all look at the website to learn a little bit more about. It's not just about cancer. Other diseases, as you'll see from these logos, are represented as well, including heart and stroke. And we're working to build across all diseases and disciplines this quality of life movement to make this healthcare change not just a priority in words, but also in action. And so you can see here this advocacy effort that's building. The map represents state-level legislation, which just started getting rolled out last year, and Rhode Island was the first state to enact our model palliative care legislation at state level, while the coalition that I feature, Patient Quality of Life Coalition, is also advancing 2 legislative pieces, the Patient-Centered Quality Care for Life Act and the Palliative Care Hospice and Education Training Act, to help support building the workforce, to support all of the cancer centers, all of the health systems in delivering this higher level of care, while we're also working to continue to promote balance in prescribing policies for pain. So there's a great deal of public policy work happening alongside what's happening at the practice change level through quality improvement. And one resource I want to feature for all of you before I turn it over to Lynne Padgett, who's going to take a deep dive with us on a really important tool, is the American Cancer Society hospital partner staff that are available in your community as your boots on the ground partners to help support you in your efforts to do quality improvement initiatives and integrate palliative care into your programs as effectively as possible. We have new resources. We're going to be providing the links to you to receive our palliative care resource guide. We have brochures, both adult and pediatric palliative care versions, and a slew of other important materials, all of which have links to additional information so that you don't need to start from scratch or reinvent any wheels whatsoever. There's a great deal of help on the ground already available, including dedicated staffing support, and ACS staff are going to be reaching out to you, and already have in terms of inviting you to this webinar, but in follow-up to make sure that we can help support the quality care improvement work that you're seeking to build within your own institution. So in terms of a quick summary of some of the action steps we hope you'll consider and invite you to think about with your teams in your cancer centers is making sure that you all together collectively sing from that same quality of life song sheet that we got from patients and families in terms of the words to use, talking about palliative care as an important part of quality care. Be sure to get to know your ACS hospital partner. Many of you may already have outstanding relationships, but if you don't, please do, because they're a valuable, critical resource to help support your efforts. And please get familiar with the resources that we're talking about here so that you can start having those robust conversations about the next steps to help enhance that integration. I'm going to turn it over to Lynne Padgett, and just as a quick reminder for those that tuned in late, we are recording this and we'll be sending out the information after the webinar early next week, together with links to some of the materials that we're covering here. So rest assured you'll be receiving all of this information in your inbox. So thank you all for your attention, and I'll hand it over to Lynne Padgett.
Hi, thanks, Rebecca. Welcome to everyone. Thank you so much for giving up part of your day to listen to this. I hope that by the end of this, you'll feel like that your time given up will actually save you time in the future by making you aware of some resources and things. So, Rebecca, thank you for helping us see how palliative care fits into a quality of life agenda. I have just a quick outline of what I'm going to go over today. And in a minute, when I hit page down, the slide will advance. That's what I'm hoping for anyway. Whee! Not happening. Okay, let me see if there's anything. So I'm going to make y'all aware of that, I'm not able to advance the slides at my computer. So Sharon, I'll let you problem solve on that. And then what I'm going to do is just briefly go over the outline, because those are not, that's not an essential slide for you to see. What I'm going to talk about today is that, here we are, sort of strategic plans for palliative care. As most of y'all know, it's become a much bigger issue in hospital and cancer center administration, through accrediting agencies, through quality initiatives. So we're going to take briefly look at the big picture and sort of the strategic picture of where it is. And then we're going to dive down into a tool that I've worked with here at NCI. It's part of the NCI Community Cancer Center program. We have a tool we worked on called the Cancer Palliative Care Matrix that is something that your tax dollars supported and hopefully that you'll find as a good return on the investment. I will sort of colloquially refer to this program, NCI Community Cancer Centers, as NCCCP. So if I slip into acronyms, that's the program I'm talking about. And we'll go over the tool development, the tool, what are its uses, how you can use it, and then some of the lessons we learned using it in our Community Cancer Center program. Okay, so we'll go on to the next slide, which based on, oh, here it is, okay. So a lot of centers, a lot of reports, such as from the IOM, practice initiatives out of ASCO, such as COPE, have all come and centered on the importance of having palliative care integrated into cancer care. So something that's not just at the end of life, but something that's incorporated and offered concurrently during treatment. So we have a wealth of information about it. Then the information was accumulated and put together into different kinds of standards, whether through the Commission on Cancer or through the COPE, the Quality Oncology Practice Initiative. And so based on my experience in cancer centers and hospital systems, that tends to result in a couple different actions. So a stressful memo comes down that says, wow, we've got lots we need to do in this area, and then three things tend to happen. And so on the next slide, I just have a quick overview of what those look like. And I refer to those as colleagues, checklists, and counting. That first picture there, that may look like some of your Commission on Cancer or Cancer Committee meetings where someone is going, we have to do something about this, or this may look like your committee where you got together to try and figure out how to implement the Commission on Cancer standards. And what tends to grow out of that are checklists, so very discrete items, people you need to talk to, things that need to be done, and then sort of needs that aren't being met, what you are doing and what you aren't doing. And then because we work in systems that like to quantify things, it's important to count. So we need to be able to show with numbers often for our administrators what we're doing. As I sometimes tell clinicians when I work with them, stories are very moving, but stories work best with administration when they're used to illustrate numbers, not take the place of numbers. Well, if we're going to count, then what are we counting? Are we counting the number of patients served, how many FTEs it takes to do this, length of stay, service lines? The question is, what do we need to be counting? So we're left with a situation on the next slide where we have a wealth of data to tell us what we should do, and we have less data to tell us how to do it. So what we need is a guide to program development. We need a tool to foster assessment of our capacity, where it is and where we want it to go. And then we need a process that facilitates communication and strategic planning. So what do we do to find these things? As part of NCCC, we went and surveyed the literature and the reports and the different resources, and we found different resources that served as one or two pieces of this, but nothing that really met our needs to track our progress and help us know what to shoot for next. So as part of NCCC, we developed a tool that we're going to talk about today on the next slide, called the NCCC Cancer Palliative Care Matrix. So brief overview of this is kind of the who, what, when, where, and why of it. Who developed this tool? This was a consensus-based instrument devised by the NCCC Palliative Care Working Group. It was then approved at the NCI level by the Scientific Board and the Program Advisory Board. What it is it was a measure to be completed by the sites participating in the program, and the number of sites ranged in different years from 14 to 30. We had 2 cohorts of sites go through. Because we needed a way to measure the program capacity and that program's development so that we would know if people were meeting their contractual obligations. We began development in 2007, and the tool was finalized in 2009. This was truly a bubbled up from the community kind of tool. I was not at NCI at the time, but scientific advisors here gave it to the Palliative Care Working Group, gave them access to resources, and then let them work on it and advised them when they hit snags. So all of this was done over the phone, over email, and through a couple of annual meetings. It's a real testament to how technology facilitates work getting done. Why did we do it? Why did we need this? If there are all these reports and resources, why did we need yet another tool? And the reason is what our sites reported to us was that lots of tools said, do you have an outpatient referral? Yes, no. Do you have inpatient referral? Yes, no. And so if they were answering questions with no's, they knew they needed to get some things together, but they didn't know how. So they might find a write-up of a case report, but maybe they were a rural setting and it was an urban center. So what were some things that carried across and illustrated the process? And then, like I said, the final reviews of the tools were, was it consistent with the evidence that we knew, and could we bring a wide variety of hospital and cancer center stakeholders into consensus on it? So the next slide is tool development. We used a couple sources. Now remember, this is starting in 2007, so we didn't have some of the great reports we have now about dying in America. Atul Gawande had not published all his New Yorker articles and his books. We didn't have certain IOM reports. So what our team worked with was the NQS, the National Quality Standards, CAPC, and an IOM report from 2001. So using that and an evidence review of the science that we had, we came up with a tool. So as we were implementing the tool, the field began to grow and change, and you can see on the next slide that in 2012, the Commission on Cancer came up with some standards that you may be familiar with in palliative care. These standards tend to focus on where are the services that you're providing and the administration of the services. Can you actually have a process that refers them? So again, helpful, but not addressing the process of development. The next development that came up was through the Quality Oncology Program Initiative, COKI, and that's on the next slide. And you can see that their end-of-life module, which is administered to participating practices once a year, also looked at some other components of delivering palliative care, but this tended to focus on patient outcomes and provider practices. So again, how do we get to where we're making sure that pain and dyspnea are addressed? How do we get to a process that looks at hospice enrollment and referrals? So, okay, that was a tool, but we still needed a process. The next issue that came up was the Delivering High Quality Cancer Care report. And again, we need to provide palliative care. How do we do it? They focused on system and provider practices. So, as you can see on the next slide, many of us were left scratching our chins saying, we have this unaddressed need. I need to execute these mandates and standards in my system, and I'm not quite sure what my first steps are. And I don't know how necessarily to conceptualize the process that's required for this. So if your systems or clinics have been facing these questions, I'm hoping that, as you see on the next slide, we can take a closer look at the NCCCP Palliative Care Matrix. We're going to actually go through it. I've got sheets of it up on each slide that we'll go through and see in just a moment. When you receive materials from this webinar, there will be a PDF as well as a QR code that you can scan with a smartphone, or you can have your children teach you how. Scan that. And you can use and distribute these. They're public domain. You're welcome to use them as well as to share them with others. So let's move on and take a look at the matrix. Now that you know what its goal was and how it was developed, hopefully you'll see this as a tool that can help you execute these mandates and begin to put a process in place. So this is the first domain of the tool, and as you can see on the left side is a category that was driven from various reports and science and different evidence and quality care standards. And then there are 5 levels. So what this does is it allows a team to look at this particular category. So for example, this one is patient symptom assessment at each physician care provider encounter. And as you can see, it covers the range of symptoms, from physical symptoms like pain and fatigue, nausea, to sort of quality of life symptoms, sexual function, and psychosocial distress. Just as a caveat, you'll see psychosocial distress matrix, and many of y'all are probably familiar with the psychosocial distress screening that's required from Commission on Cancer. We also have a psychosocial care matrix assessment tool like this that focuses solely on psychosocial care. So that's something that you can Google and find, or I can make sure that the PDF of it goes out also. So again, to come back to this, we're looking at symptoms. So as you look at your cancer care system, what level are you at right now? Are you at level 1, where it's not really documented at all, or where there's inconsistent documentation, maybe only if a patient comes in a pain crisis? Or have you progressed through different steps to where you have consistent documentation, but sometimes it's just physician or patient report, sometimes it's a 0 to 10 scale, maybe sometimes it's a physical functioning scale where patients are checking off what activities of daily living they can do or not do. Consistent documentation with consistent tools, so you're using the same tool every time across the center, across patient populations, and it has some sort of validation to it. And then level 5 would be sequential comparisons across time. So you're doing this more than just once, right? You're doing this across the continuum of patient care. Now, it's important to state that we realized when we put this together, not every system can be a level 5 system in every area. That depending on the strengths and weaknesses of your system, there are going to be areas that are easier to improve, areas where you have a lot of resources, and areas where you don't. So that's okay. So our smaller systems, some of them that were in very rural areas like Nebraska or Maine, also found this useful, even though they weren't sort of full service facilities. So I'm hoping that it'll reach across this also. So let's move on and look through some of the other items. Here are some of the other domains, and what you'll start to see is that first item looked at a patient assessment. Okay, that's very consistent with the COPE standards that were used. What are you actually documenting that you're doing with patient care? One of the strengths of this tool, though, is that it doesn't just focus on provider, and patient behaviors, but that we start to look at some system variables. So what system resources are also available? So as you can see here, as we go through this domain, palliative care and supportive care services are provided across the continuum of patient care settings. So this, for a lot of facilities, a lot of cancer care centers, if you're an inpatient, you can get palliative care. There's a consult team or, you know, a part-time or full-time nurse practitioner or social worker who can come work with you. But if you're only being treated, as the growing trend in cancer treatment now is, if you're only being treated through the outpatient setting, what does that mean? Are you connected to palliative care services or supportive care, either through in-house services or referral? So again, this is a way to look at where your services are offered. One of the challenging areas is in patient identification and case finding for palliative care services. So a very frequent refrain is that the palliative care teams say that you only refer to us when you're ready to send people to hospice. We're not a hospice placement team, we're a palliative care team. And then a lot of the physicians are like, right, but I don't want to let go of my patient, or maybe a patient is an advanced stage 4 breast cancer patient, so they're not necessarily immediately terminal. They may not be qualifying for hospice, but they may have devastating fatigue or pain. So at a level 5 center, perhaps even regardless of stage, cancer patients and survivors can be referred to palliative care when they have the resources to treat different symptoms, so taking a quality of life perspective. As you'll see on the matrix, we split out hospice care services because hospice we viewed as a subset of palliative care. And again, you can see hospice is offered when death is imminent, or hospice is an option that's presented to patients at various points in the treatment continuum, perhaps when their disease advances or when they're not responding to chemotherapy. Lastly, where can patients access or get referrals? Are referrals only permitted from oncologists, or are they permitted from other staff who may have a different experience with the patient? Let's move on to the next area. What are barriers to palliative care? This is actually referring to the patient level. I'm sure a lot of y'all can discuss system barriers or EHR barriers, but what are the barriers to palliative care? There are different cultural reticence to talking about death, or feeling that perhaps not pursuing every option is not consistent with a person's value system. So those are some things that we want teams and systems to be able to respond to based on who's there. So for example, one of our sites in Maine, if you looked at them in terms of underserved populations, they were like 98% white. So if you look at them, you might say, well, that's not very diverse, right? So they probably don't have that many barriers to palliative care. But what we found is that within that vast array of white Maine residents who were accessing care there, is that there were certain subsets, either for religious reasons or perhaps a lack of education, for different reasons, that experience different barriers to palliative care. So we want your system to have a way to kind of measure how you're approaching that. This is also a good example to see that levels 1, 3, and 5 have markers in them. Levels 2 and 4 do not, and that's because we felt like there wasn't necessarily 5 steps there. So again, you can kind of rank yourself on there if you feel like you're in between, but most of the domains have 5 steps. If we move on to the next one, you'll see that we're looking at quality and impact. So how are we using measures to give our system and ourselves feedback about what we're doing? As you know, that can be challenging, which is why we sometimes tell lots of stories. So this is important to remember that we need to think about data that's important to patients, so maybe patient satisfaction, data that's important to the palliative care team, as well as data that's important to the quality cancer center team, to the financial or administrative team at the hospital, maybe to the IT team. So there are lots of different ways to think about that, but we want to make sure if you've got a service line in a cancer center, we want to be able to see who the stakeholders are and how they're measuring success. Another area that's important to assess is the palliative care leadership. So as you can see, leadership, when I first began working in palliative care, was pretty much if you were interested and had attended a course somewhere, you could be a leader. As the field has become more advanced and a little more solidified and more training is available, this is a way to sort of conceptualize levels of training and expertise all the way up to a specialty certified physician lead. Let's move on to the next slide. I'm going to pause for a moment because I realize this is a lot of information and a lot of domains to think about. So again, hopefully you'll start to see, I'm hoping that each of you are starting to go, wow, that's an area we're doing good in, or this is an area where we really struggle, or this is an area where I hadn't thought about as falling under the responsibilities of our team. So again, that's another way this tool can be used, and we'll talk a little bit more about that once we finish going through it. So palliative care also wants to focus not just on team leadership, but on team education, training, and awareness. In times of financial crunches, this is somewhere that often gets cut in hospital and cancer care systems. So this is a way, again, to self-assess your program there. How do we educate patients around palliative care or self-management of maybe their pain or their fatigue? Rebecca highlighted some information about palliative care in general that's available. ACS and other organizations have information about best practices and patient education literature. Is your site taking advantage of those? You can either use those as a place to jump off, or you can use those to save you time to work on other projects by not writing the pamphlets, but by relying on ACS's expertise in this area. Advanced care planning, your hospital or cancer center probably has something when someone comes in through the emergency room, or maybe they're admitted for a scheduled surgery, where they complete some sort of advanced care planning or DNR order. This domain gives you a way to say, how are we doing that consistently? Is it documented in the chart? Does the family know about it? Does that information get updated regularly, or does that information follow the patient through different clinics and changes? And let's go on to the next one. We have this page and one more of the matrix tool in case you were wondering. There's 17 domains. So we've got 5 more to just go through. How you disseminate advanced care plans. And then something that I really, really like about this a tool that was developed is palliative care does not exist on an island. In palliative care, as treating professionals, we look not just to the patient and the family. We don't just provide medical care. We provide spiritual and psychosocial care. And so I think it's important to think organizationally that we don't want palliative care to be a silo, but that we want to interact and use resources and do cross-training with other services in the hospital that also focus on quality of life outcomes. So 3 of the services listed here include rehab, psychosocial interventions, or your psychosocial team, and your spiritual care program. Spiritual care programs are often naturally involved in palliative care. And one of our sites actually did a survey to see how much their palliative care teams worked with their psychosocial teams, and there was really a lot of variance in that, and so that became an area where some of our sites mentored others in terms of really working on how can we improve these relationships with psychosocial care and perhaps with case management to where everybody is getting to do what they do best, and we get to serve and help each other and really improve the patient and family experience. And then, of course, rehab services. All right, let's go on and look at the last domain on the care matrix. And this, if you have talked to palliative care staff or watched them do what they do, or if you're a staff member, you know the importance of support. To do the work of palliative care, is emotionally demanding and fatiguing, and what kind of support is there in the system for your team. We looked at education in an earlier domain, but this includes things like case conferences for difficult cases or Schwartz Center rounds. How do you respond to maybe changes in your system that may have impacted the palliative care team? And again, it just looks at a systematized way of doing that. Do you never do that, or is it maybe only crisis-driven? Do you do something annually, or is there a monthly way to really cope with some of the struggles that do this, of doing this work? So those are the areas. I'm going to talk for just a couple of minutes about things we learned about using the matrix, and then we should have a few minutes for questions. So if you'll go on to the next slide. Here is the QR code. Now, when the slides are made available to you, this will be there, or right now you can whip out your smartphone and scan it and download the document. So let's move now to how to use the palliative care matrix. It probably makes sense to all of you that you can use it to assess where you're at and identify the areas where you want to grow. We actually, because we worked across multiple systems, we had teams who were strong in certain areas. Maybe they were very good at symptom assessment, mentor some of our teams who had struggled or had a low score in a particular domain. So that's a way to do it if you're working in a system where you've got multiple sites. Program evaluation and quality improvement as part of COC and other accreditation agencies like COPE. We're often asked to perform a quality improvement metric or area annually or biannually, and so this is a nice quantifiable way to do it and to show the growth. Two things that popped up when we've interviewed sites about using this tool is that the sites, the palliative care team said that this was an excellent communication tool. So often, like we use communication tools to talk about advanced care planning, they found that this was an excellent communication tool to talk to their administration. So whether it was the quality team, the financial team, a way to where everyone could be on the same page when looking at a service and evaluation and needs and areas of growth. And then, of course, it was very helpful in strategic planning. So often, as clinicians, if we want to advocate for our services, we're like, we need another person here. The load is too heavy. Whereas using a tool like this allows us to say, we need another person because we want to increase our ability to develop our program in a particular area. And to do that, we need an additional half-time administrative and clinical FTE, just to use an example. So let's move on to the next slide, but I hope that those are some ways that you can see it. We looked, I'm just going to very quickly run through this. We looked at two quality-related domains on the matrix to kind of see over a 2-year period which areas were the sites made the most and then that had the most challenges for progress. So we're going to look at symptom assessment and identification for palliative care services. If you'll go on to the next slide, what you'll be able to see is that the biggest example, our biggest success in measuring quality improvement, this is over a 3-year period, sorry about that, was in the first domain, assessing patient symptoms when they encounter either any kind of care provider or a physician in the cancer center. So as you can see in 2010, 13 of 21 NCCC sites scored at levels 1 or 2. No symptom assessments were documented, or it was very inconsistent. And after 3 years of concerted effort, and it looked different across the sites, 13 out of the 21 sites were able to move up to levels 4 or 5. Consistent documentation with consistent tools, and then multiple documentations over time so that you could look at trajectories within a patient or within a clinic. Let's go on to the next slide. Here's an area that turned out to be much more challenging than we thought going in. So patient identification or case finding for palliative care services, what you can see is that in 2010, 16 of the 21 sites, so that comes out to about 3/4, I think, typically only end-of-life patients or advanced stage cancer, typically stage 4 with very, very severe symptoms, were referred to palliative care. And 3 years later, despite education programs and relationship building, 15 of the 21 sites were still at level 1 or level 2. So as you experience day to day, or as you hear this complaint in your hospital system, it's a cultural issue, and it's difficult to make movement on. So that's an area of significant challenge. Let's go on to the next slide. We learned some lessons by using this over the course of the program, that this is not a one-size-fits-all process. We engaged in, we required the sites to use the matrix annually. Some of them preferred to do it quarterly, sometimes biannually, and that there was no one way to improve a domain. You need to leverage the strengths of your system. What your system is good at, do some more of. What resources do you already have, whether they're internal or external? We all now know that you all have ACS as an external resource, as well as this tool that can hopefully help you as you confront challenges in your system. I always say that it's easier to start where people are happy to see you, where there's some enthusiasm. If you want to improve palliative care services, what stakeholders can you also get in that pull onto your team that are interested? It's sometimes easier to start where high levels of patient distress exist. So for example, a lot of our centers had really well-developed breast health centers and a lot of stage 4 patients, so they thought that might be a good place to start. Yet we often found that some of the more high disease burden cancers like head and neck or gynec cancers were actually more receptive to perhaps earlier palliative care referrals or working with the team. And then pilot. Go in, pilot an initiative, evaluate it, tweak it, and then take it to the next place. Okay, so those were the lessons we learned from it. Next slide. So what can you do in just a few minutes when you all get off the phone? Assemble a group of stakeholders to meet regularly. I always say don't be a captive of your organizational chart. Invite the people who understand and who get things done, regardless of their title. You want representation from across your cancer center. You want consensus building discussions. Collect lots of examples for your domains and assess where your resources are needed. Next slide. I hope that this has given y'all some tools that you can use. I want to at least leave a few minutes for questions. And I also want to say that while I am presenting this matrix, it is not my work. It is the work of a fabulous group of hospitals and dedicated people who did this on their own time. They didn't receive any glory or money for it. So I want to thank all of them for hopefully providing a tool that I hope will be really helpful to each of you in your cancer care systems. Thank you.
Great. Lynn, thank you so much to both you and Rebecca. This is Stephanie Van Winkle again, for those of you on the phone. As a reminder, the call or the webinar is being recorded, and we will have a recording link as well as slide deck and additional resources sent out to all of you next week. We'd like to take a few moments for some questions and answers, and I did see one pop up for Lynn during her presentation. The question is, are these tools in the process of being validated?
Oh, I'm glad you asked that. So this tool has not been validated in this from a statistical sense. And so what that means is we don't know, for example, if moving from a level 2 to a level 3 in every domain represents the same amount of effort. What we have done is we've developed some statistical techniques to analyze data, and we also encourage people to not add up total scores, but to look at the scores across domains. If you have specific questions about how to analyze data like this, Google my name and NCI, and it will take you to my email address, and shoot me an email.
Great. Thank you so much for that, Lynn. And as a reminder, if there are additional questions, you can enter them for the panelists in the Q&A section. We did have another question that was answered in the Q&A, but for those of you on the phone who did not see that or on the webinar, there was a question that came up about some of the resources. And Rebecca, I thought you could talk about some of the resources we'll be sending out next week.
Sure, I'd be happy to, Stephanie. One of the key things that we realized is how helpful and efficient it is for folks to have one document handy on their computer that has links to more detailed information as a one-stop shopping experience, if you will. And that's what the American Cancer Society's Palliative Care Resource Guide really represents. There's a short summary that's just 2 pages long that provides a couple of links and sort of the very bare bones value proposition of the importance of palliative care in oncology. And then there's a longer but still electronic document that synthesizes that information in more detail and sets out the quality care standards and the different resources available to help. And then the third piece in that trilogy, if you will, is the hospital partner staff of the American Cancer Society on the ground in your community to help. They have an engagement guide as follow-up to help support you in working through this matrix and some of the other tools to help figure out where you're at and how the Cancer Society can help support your efforts in moving to the next level. I did see also a question about pain management specifically, and I'll highlight 2 things there. We're doing a great deal of work in the public policy domain around pain management, but also there was an article that published in CA, a cancer journal for cancer clinicians, that is linked to inside that resource guide as well, that helps provide some information about the lay of the land currently. And next week, a webinar on pain management and a research project around communication between providers and patients in pain medication use, storage, disposal is being offered, and you'll all be receiving a link to information about that webinar happening next week that's focusing on pain control. But it's also one of the purposes of these webinars is to find out what other areas do you want to have and hear from the American Cancer Society about to help support your work. So we will also keep track of your suggestions for additional webinars and offerings that take us in these directions that you all need to know about.
I will be sending out the link to the pain management webinar to put on your calendar. It is April the 29th, and I believe that it's at noon Eastern. So you may want to save that time on your calendar if you're interested in attending that webinar. I think we're about up to our time, but we do have another question. And I think for you, Julia, there's a mix of secondary and primary palliative care recommendations without recognizing the distinction. And it says well, I'm trying to read this thing. It's the question about how ASCO and the COC are mandating that oncologists start practicing. And I don't know if I read that correctly. You might be able to view it, Julia, in the Q&A.
Yeah, this is Lynn, and I saw those questions, and I thought they were extraordinarily interesting. So the first question about primary and specialty palliative care, the matrix, it was originally developed sort of as that language was coming into use. So it doesn't, that's why it, I think, reflects a mix of items, but without actually using that specific language. Also, I think part of that is its inherent flexibility in the system. There are going to be some systems where the oncologists jump in and are happy to practice primary palliative care, and there are going to be some systems where perhaps that's not their primary focus. And so the extent of where teams step in and where their skill set fits in the specialty to primary range is going to be a little more site dependent. I hope that's helpful. And then I think the other question was about our oncologists who already say they do palliative care. I'm going to assume, and I may be wrong, but I'm going to assume that the hint behind that question is, wow, we don't think they do it. So I would suggest a conversation that asks them what parts they do best and how your team can fill in the gaps, given that they are focused on oncology and that's what their training is. So find out what they think they're doing. It may be that they provide hospice referrals and they think that that's it, and encourage them to go with what they can do and do well, and then paint a picture of your team not as addressing their weaknesses, but as in filling in the gaps that they don't have the time to do.
Wonderful. And Rebecca and Lynn, if you'd like to take one more question or make any additional comments. I know there's one on here, and I think it's being answered in the Q&A, but tips for teams starting from scratch and how to get started. And I think, Rebecca, there will probably be a lot of good resources in the resource guide, and thought you might be able to speak to that.
Sure, Stephanie, and that's a really important question, and what we don't want you to do is reinvent the wheel. The resource guide is a great first step to become familiar with. Of course, the Center to Advance Palliative Care has outstanding technical assistance materials available as sort of a follow-up, as does the American Cancer Society and many others. So working with us to help support you in figuring out where should we start is one wonderful next step to take next week after you receive the materials, and be thinking about where is it that we want to head and what are the steps to get there. There's a number of resources already available to get you started, get you rolling, get your team excited, and then we want to help support you with those next steps.
Wonderful. And we are a little bit past our time, so we'll have to end now, but I would like to remind all of you on exit, if you can answer a few of the survey questions, it'll take you about one or 2 minutes. We'd love to hear from you about future topics. I know I've already spoken to Rebecca about doing some additional webinars on the topic of palliative care, so we'd really like to hear from you about what your interest levels are in different topics. And thank you so much for joining us this afternoon. And again, you'll be hearing from us next week with some additional follow-up and resources.